Hello, everybody. It's Laura Young from the Department of Psychiatry at UT Tyler Health Science Center, and we are glad that you are joining us today. I have Dr. Kimberly Gushanis with us today from UTMB. She is going to be presenting for us trauma assessment and diagnosis in pediatric primary care. Dr. Gushanis, if you would like to go ahead and take that screen back, I'm going to stop presenting right now. You are welcome to go ahead and put your primary screen on. Yep, perfect. And I'm excited to go ahead and introduce Dr. Gushanis today. She is a licensed psychologist and assistant professor at the University of Texas Medical Branch in the Department of Psychiatry and Behavioral Sciences. She received her PhD from the University of Texas at Austin, where she studied school psychology and integrated pediatric healthcare. Her doctoral training and fellowship at Dell Medical Center in Austin and at Texas Children's Hospital in Houston allowed her to further her expertise in trauma-informed and pediatric psychology and consultation. Dr. Gushanis' work at UTMB currently revolves around providing trauma-informed services through the Texas Child Mental Health Care Consortium. So she's part of us, which helps youth and families and communities affected by significant stressful events, disaster, and suicide. She's passionate about improving equity and access to culturally sensitive preventative mental health care, and sees her role as an educator, clinician, and researcher as essential components to that mission. Dr. Gushanis provides clinical services to Texas schools through the TCHAT program, which stands for Texas Child Health Access Through Telemedicine, one of our initiatives through the Texas Child Mental Health Care Consortium initiative, as well as research investigation for the Texas Youth Depression, Suicide, and Trauma Research Networks. She also serves as the Early Childhood Division Chair of the Texas Psychological Association and volunteers on the board of Exploration Green, a local conservation project in the Clear Lake area. So I'd like you to welcome Dr. Gushanis with us today, and it's all yours, ma'am.
Thank you so much, Laura. And thank you all for sitting through that. I need to ask them to reduce the length of my bio for you to read. I appreciate that. Well, so like you just heard, let me move this out of your way. I am a pediatric psychologist. I do have a background in working in integrated and primary care settings, and my primary focus of all of my clinical work, research, and teaching is trauma-informed care. So we'll talk a little bit more about this in a second, but when I say trauma, I do mean particularly traumatic stress, but I also have quite a history of working in different medical facilities, working with medical trauma as well. Can I ask whoever is not muted to go ahead and mute your mics, if you can check that for me? I think you got it. Thank you so much. I am very pregnant right now and very easily distracted, so I appreciate you taking care of that for me. So we'll go ahead and get started. And just some initial learning objectives for you. My goal is for you by the end of this presentation to be able to recognize the tenets of trauma-informed approaches to pediatrics, describe the prevalence, symptom presentation, and risk factors for common traumas that you will see in pediatric patients, differentiate between adjustment versus acute and post-traumatic stress reactions, be able to restate the rationale for why we should all be screening and providing either preventative or treatment intervention for traumatic stress in the primary care setting. And when I say we, I mean everyone involved. We'll talk about that too. Incorporate anticipatory and preventative intervention strategies, and understand and utilize evidence-based resources to provide additional training for yourselves, your teams, but also for your patients and their caregivers. So the way that I plan to do this today is I'm going to give you a little bit of a rationale and very brief overview of broad trauma-informed care for pediatrics. It does say PCPs, but I understand that not everyone here is necessarily a PCP. PCP adjacent is perfectly fine. As you'll see in a second, trauma-informed care models really incorporate everyone involved in the building. So this really applies to anybody interacting with patients in their visits. We will also talk about assessing and diagnosing pediatric traumatic stress. So I will define exactly what I mean by that. We'll go through some signs and symptoms. We'll talk a little bit about risk and recovery factors relative to pediatric traumas. And I'll talk to you a little bit about the phase model of how we recommend responding to post-traumatic stress, as well as a slide that you're welcome to screenshot, or I'm sure these will be available later, with some of the most common recommended screening tools that can be used easily in primary care settings. I also am known to offer lots of resources for continued education, so there'll be a great slide full of links and resources for you for later. And if we have time, I'm happy to coordinate discussion on a case example that any of you might have. And if not, I have a couple in mind that I could always talk about. And of course, I'll do my best to leave time for questions at the end. So the role of the pediatrician or the pediatric provider in trauma-informed care, really what I want to emphasize is that you are the front lines here. So we know that at least 54% of kids in the United States will experience a trauma before the age of 18. And this data comes from prior to COVID. So we know that in the last couple of years alone, there have been significant stressors that have occurred throughout our country and globally. So this number is likely a lot higher than this initial data suggests. We also know that about 20% of injured children and about 12 to 15% of children diagnosed as ill actually meet criteria for PTSD, whether that's related to their injury or illness or related to treatment for either of those things, or secondary trauma that's not related to their medical complaints. A significant portion of them are experiencing symptoms. And we know this is a problem because trauma has a significant impact on our health, both socially and in terms of health outcomes that you're directly monitoring in your care with them. So you really are the front lines of care. You're the first responders for the average child's wellness. Most parents are going to come to you with concerns before they go anywhere else. And therefore, you really have the greatest potential for influencing how early we identify these issues and how we respond to them and how families and communities respond to them. I know that a lot of people report feeling a lack of knowledge, a lack of time, a lack of resources as really big barriers. So the purpose of this talk today is to help really simplify. It doesn't take a lot to be preventative in response to trauma exposure for kids. And hopefully by the end of this, you feel like you have enough knowledge and resources to at least take a very tiny first step to responding if this is showing up in your visits. Just a quick overview, SAMHSA is really who defined the trauma-informed care approach. It's probably copyrighted and trademarked in various ways. There's lots of different resources online that can kind of give you this broad overview. But my favorite one, the one that I think is the easiest and most comprehensive for us to remember, is called their 4 R's approach. They're intended to be kind of a broad stance on addressing high incidence trauma and risk factors. So we know that the goal of trauma-informed care, and the data says that if we approach youth and really just any human as kind of like a universal precautions approach like we do for bloodborne pathogens, if we approach trauma in a very similar way, we have a really great chance of reducing some of those negative health and social outcomes that we know are associated with being exposed to trauma and adversity in early childhood. There is a lot of evidence that supports the link between early childhood trauma exposure and later health and social risk factors and outcomes. So the goal of this is to really provide a stance, like this universal precautions approach. We want to just basically expect, but by the time a child turns 18, they're going to have experienced a significant traumatic event. Whether or not that's traumatic in terms of post-traumatic stress, we'll talk about that in a second, how to determine the difference. So you can read up on these later on your own. They are included in the resource links at the end. But the really broad overview is to realize that trauma has a very widespread impact on our country, on our youth, and that there are several risk factors that point to when someone is exposed to a traumatic event, their likelihood of suffering as a result. We'll talk more about those today. We also want to recognize the specific signs and symptoms of post-traumatic stress so that we know what we're looking for. This includes in our patients, their families, their caregivers, in our communities, and our coworkers, and ourselves. Understanding what the signs and symptoms look like and actively screening for them is really the only way to effectively recognize what's happening in our populations that we serve. And then responding effectively with full integration of knowledge about trauma into your practice policies, the procedures, and how you actually perform your practice with individual patients and families. So really thinking comprehensively from the door they walk into, who greets them, if there's a security officer there versus, just an information desk employee, all the way down to the end of providing physical exams in your appointments and making sure patients have heads up what's coming when you're interacting with them in their visits. And then finally, resisting re-traumatization, which really kind of envelopes the entire 4Rs approach, where we really want to actively shape our environments, the things that are around our patients when they're coming in for care, to make sure that we're doing our best to prevent re-traumatizing high incidence cases. And I'm happy to clarify that a little bit more if anyone has questions at the end. So when I say trauma, it doesn't always mean the type of trauma that you in the medical field have been trained on. So while medical trauma can be included as a psychological trauma for many people, it is a more broad term that's used across the literature to suggest, in a medical setting, the term trauma can refer to physical or psychological trauma. A major trauma is typically considered an injury or a combination of injuries that have been life-threatening. For psychological trauma, that can absolutely be true, but it does not necessarily mean that there was injury suffered or actual threat. It has to only be perceived. So for a child, or for anyone, psychological trauma is very subjective. So you might have two families that come in experiencing a very similar motor vehicle collision. One person in the car dies or the other person dies, and one child comes out of that perfectly fine, goes back to school completely normal, and the other child acts completely differently. It shows a lot of signs of stress, nightmares, things like that, can't get in the car again without a struggle. That's the subjective nature of psychological trauma. So it's not quite cut and dry as the medical definition. So just keep that in mind throughout this. When I say trauma, I mean the psychological version. It's a little more comprehensive and a lot more subjective. There we go. So this is just an overview of some of the primary sources that we've identified in the literature to be potential sources of traumatic stress in children. So these are kind of the top 3 categories. You'll see external circumstances and events as the highest. So these are typically traumas that originate outside of the home or family. It includes things like community violence, war, natural disasters, unintentional injuries like motor vehicle accidents, terrorism and hate crimes, discrimination, and immigrant and refugee traumas, including the move from their country of origin to the United States and what happens once they get here. The caregiver-related traumas are really more family-based. That's typically how I think about them. They involve someone that the child loves or should be responsible for them. This is where we see things like domestic violence, abuse, neglect, bereavement due to caregiver death or very close family member, friend death, and separation from a caregiver, including things like incarceration or the border crisis. All of these things are very prevalent throughout the entire state of Texas. So it's likely that all of you have experienced a patient encounter with at least one of these things. And then finally, medical trauma, which is one of the top presentations for traumatic stress in children. So anything related to medical or health-related events, including the actual event, injury, or diagnosis, as well as the treatment, especially when they're invasive or they're very scary and feel out of control. Apologize also for my frequent grunting. It's very bad allergy season here in Houston. So the kind of top 4 and really 5, but mostly 4 signs of post-traumatic stress reactions in children look like this. So we can objectively know the criteria, but unless we're actively screening for these things, detecting and differentiating these from just normal childhood complaints that come into your office. We know about 33% of primary care visits, the chief complaint is something behavioral or mood related for kids. So there's a high chance that some of these things come in. But really understanding how they relate to each other when there has been a trauma exposure is really important. So we're going to dig into each of these categories of symptoms to talk about what they might look like in your office or in your visits. So the first one is re-experiencing, which are intrusive experiences related to what happened to them. So this can include things like intrusive thoughts or images that pop into their head when they don't want them to, similar to what you might have heard of with like veterans who experience flashbacks. That happens with children too, so they feel like it's happening all over again. It's almost like they're transported in their head to the actual event. It can also come at night, like nightmares, or just memories that pop up throughout the day. It doesn't have to feel like they're re-experiencing it, but the trauma is re-experienced through the memory. And then it's important to recognize that intrusive implies that these things are unwanted. So it's typically distressing for the child or for the individual. It feels scary for them, or it makes them feel really angry or nervous. So these are just some examples of what might come up in your visits. So like patients will say like, every time I close my eyes, or I don't like going to sleep because then I think about this, or I can't sleep because I can't stop thinking about this. It feels like it's happening all over again. You might find parents complaining that a child cries or becomes very upset at certain reminders, or they're having specific dreams that are distressing. One thing to note is that nightmares don't have to be related to the trauma. They can be actually just in general distressing nightmares, but that can be kind of a symptom of the HPA axis being overwhelmed with stress. Avoidance is the second category of symptoms of post-traumatic stress reactions. That basically means what it sounds like, strongly avoiding things that remind them of what happened. So that it can include people, places, situations, words, objects, smells, sounds. The world becomes very small when you start trying to keep yourself from experiencing anything that reminds you of the trauma. And that's one of the biggest disabling factors of having PTSD. So you might hear patients say, I try not to talk about it, or they won't talk to me. You might see them say things like, I'm never going back there, or I'll just never do that again. So those are some signs of avoidant behavior or thinking. shifts in cognition or mood to the negative. So usually that means it kind of seems like there's a negative filter, like they only see things through a negative light. That includes themselves, other people, even the world, just in general being unsafe or losing a sense of trust in other people or themselves or the world in general. A lot of times this is what we see lead to intense anxiety and fear about something happening again. We also see this lead to increased avoidance behaviors because they're so worried and thinking about all these negative changes or lack of trust and things being okay that they start to retreat from functioning. This also includes a lot of excessive blame or anger towards themselves or other people, feeling unworthy or feeling guilty, like they should have done something to affect the outcomes of this trauma. We also see a lot of patients completely shut down, become numb or detached. And that's where these dissociative features here come in. Patients kind of start to experience like outer body experiences because their system has shut everything down to protect them from these really negative thoughts and feelings. And then any other kind of negative beliefs subsequent to the isolation, the avoidance that they might experience. Hi, for those of you that just joined, please mute your mics for us. Appreciate that. Just again, some examples of what this might sound like or look like in your office, and this can come from the patient themselves or the parents. Last primary category of symptoms of traumatic stress include hyperarousal. So these are things that we generally will see like a simulated startle response, hypervigilance, so always kind of feeling like they need to be looking over their shoulder for something bad to happen, but also some physical symptoms like increased irritability, difficulty sleeping or eating, not being able to relax, having a lot of heart palpitations or difficulty breathing. You'll see frequently patients come in for chest pains, similar to panic symptoms. Difficulties concentrating or learning in school. A lot of kids with trauma exposure are misdiagnosed as ADHD because they're having such a hard time focusing afterwards. So that's what some of this can look like. Again, you'll hear things like, I know that doctors say it's safe, but I don't want to put weight on this leg, that I have a severe injury on. So they are non-adherent to treatment because of their fear or trying to be overly careful. Parents will do this as well. Or being easily startled by loud sounds or jumpy, being very irritable in general, or having trouble focusing. It's much less rare in young children, but you will see on occasion some of our older kids and adolescents, young adults experiencing these dissociative features, which is a very common reaction to severe trauma. So it's not like a psychotic episode or anything like that. It should be ruled out by a mental health provider, but typically this is just kind of one of those brain's protective mechanisms, and it can be really distressing for some kids and families. So just a quick overview, when we're exposed to a severe threat, whether that's through injury or medical trauma or maltreatment or natural disaster, our bodies are primed to respond for survival. That's the function of our sympathetic, parasympathetic nervous system. After a trauma, especially when we are going through medical follow-ups, our body is still processing what's happening and often has trouble turning that alarm system off. So that fight or flight response, that stress response system is activated anytime that threat is detected. And so when a child experiences a reminder of that trauma, it sends that cycle back into overdrive. Typically, their sense of safety is completely shaken, especially when they're hospitalized. That feeling of being out of control is really intense. And that's one of the things that is the hardest for children. They have a lack of control in general, but especially when they're hospitalized for medical trauma, or when they're having to receive follow-up care, it can feel really distressing for them. And we know that in pediatric traumas that pain is a primary reminder. So pain management and assessment is a really important part of preventative care for traumatic stress. It falls into that re-traumatization category. Another thing to really be aware of is that trauma onset, PTSD onset can actually develop years later. So really getting a thorough understanding of your patients, especially those that you have continuity with, can be really important for understanding, like, they've experienced this thing right now, they seem to be doing okay, but there is no indication that that might not worsen for them over time, development, as things change in their life or as they experience additional stressors. On the other hand, we have to remember that not everything is trauma. So not everything that feels scary or intense is a traumatic situation. So this is where screening using evidence-based assessments can come in very handy to help you differentiate trauma exposure from stress or from general difficult situations. And even if there are acute stressors present after a trauma, most kids are very resilient. So not all the time does PTSD develop just because they've experienced something traumatic. A lot of kids have a lot of protective factors and do really well as long as you're taking care of them, their parents are on board, we're really helping promote them getting back to a normal routine. That being said, there are some populations that you might come across that are higher risk. I'm not going to read these to you, but some of the biggest risk factors that we see in Texas are immigrant and refugee children, poverty, even more so some of these biological traits, genetic health factors, underrepresented groups, whether that be racially, ethnically, religiously, sexual and gender diverse groups, neurodiverse groups, overweight and obese groups, and of course, early childhood and chronic illness, or kids, maybe not chronic necessarily, but who have a difficult diagnosis. And then a surprising statistic to me when I first started my training in this field was that about 80% of pediatric patients who come into your office after a life-threatening event experience some form of traumatic stress reaction. So we really want to think about this in an ecological sense, really think about how do we know what predicts how severe this is going to be for our patients and what this is going to be like moving forward, the things that we need to be monitoring, and the areas that we need to really be promoting their strengths and helping to reduce risk factors. So I know you have a limitation in a medical setting, mostly with time, but also sometimes it's hard to not let these things fall through the cracks, but just to be aware of the types of traumas that kids experience really play an impact on how severe. So even though I said it was subjective, we do know that kids are more likely to experience traumatic stress reactions when there has been an actual death or injury to themselves or to someone very close to them, someone that they loved, including pets, as well as any kind of death, grief, traumatic bereavement. So these things typically involve more intense fear and helplessness, and sometimes like very horrific circumstances. So those tend to have a higher response of PTSD for some kids. How often this happens to them, how many times they've been exposed, as those things increase, so does the risk for PTSD. If they have any premorbid mental health or significant health factors that are playing a role in their ability to manage stress in general, they're more likely to experience PTSD. If they tend to be avoidant copers, they just try not to deal with things, or they try to shut things down. That's another risk factor. And so our job is to really help them balance these risk factors that we see with protective factors and their systems of support. And what we know is that the strongest predictor of a child recovering from a traumatic event is having a safe, stable, and nurturing environment. So really help promoting parents, caregivers, communicating with their schools to make sure the kid has what they need outside of your office, and then making sure that you're following them closely as needed. So really quick, one of my favorite charts on how to do this effectively across the span of a traumatic exposure comes from the Center for Pediatric Traumatic Stress out of CHOP. And this was published in a paper a couple years ago. It's also provided, you'll see down at the bottom, this reference for Healthcare Toolbox, which is one of my favorite websites. If you have never seen it for medical trauma, please look at that for pediatric medical trauma. And what we're talking about today here is this, this peri-trauma. So we have traumatic exposure. There's a potentially traumatic event. This is an objective fact, but the experience or perception of that event is subjective. So right here, we're just monitoring. In pediatric primary care, we're monitoring to see how to address what happened to them. So within the first 30 days of a traumatic event, it is normal for a kid to experience all sorts of symptoms of PTSD. That's called the acute trauma phase or the acute stress response. After 30 days, those things naturally should start to decrease, especially if we're giving them education, the parents are supporting them, they're supported getting back to school, back to their normal routines. We should see those symptoms start to subside. But if it's hit 30 days and they're still experiencing severe distress and symptoms of post-traumatic stress, that puts them at risk from moving beyond this acute 30 days to more persistent PTS symptoms that we need to be addressing more clinically. One of my favorite models for how to do so is described. This is very similar to any kind of public health model, tiered intervention model if you're in the school system, very similar to these ideas where we need to take these universal precautions, assume everyone's been exposed and screened for exposure, and then targeted intervention, education, providing really good anticipatory guidance if you know there's been a trauma exposure, and then making sure patients know where to go if they have questions about what to do next. And then, of course, if we're screening, we're communicating, we're identifying patients who are at risk or who are experiencing symptoms, and we're referring them to the appropriate providers, which is that top tier. Sorry, I froze up. Let's see. There we go. So some of my favorite screening tools that I recommend, these are tools that I recommended here at UTMB in our emergency departments. I've used them at Dell Children's and Texas Children's and our traumatic consultation clinics for trauma follow-up and inpatient trauma care. So these are really great resources. All of these are free, and I think that's important. There are some other really excellent resources, but you have to pay for them. So these are the ones that I would recommend looking into first. Again, you'll have access to this later, but they range anywhere from 3 to 15 to 20 questions. It just depends on kind of the level of screening. So I usually recommend very short screeners, yes or no questions. Does this ever happen to you? Up front, and then for that more targeted and clinical intervention, you can start asking more specifically about symptoms using some of these assessments. So the National Child Traumatic Stress Network defines trauma-informed healthcare as medical care in which all parties involved assess, recognize, and respond to the effects of trauma exposure on children, on caregivers, and on ourselves. So it's a very comprehensive model of thinking about how these things impact our communities and ourselves. So it's very patient-centered in a way. We are moving away from this idea of like, what's wrong with you? Why are you doing this? What's happening? To what's happened to you. So moving from this kind of symptom-focused explanation to contextual explanations for what we see in our patients. And then this is the psychologist in me also moving a little bit beyond that to a strengths-based approach. So patient-centered strengths-based is really identifying what are the protective factors that are already here, including follow-up with you as their medical provider, and how can I help them maximize these things that are really protective for them. Good patient relationships, patient and caregiver relationships, relationships with the school setting as needed, and any other community institutions or providers that can be helpful for protecting this child from further exposure or risk. As a pediatric provider, you are in an especially prime position to influence some of these trajectories. One, because families really trust you. They're coming to you to fix their problems. You're the first line for that. They come to me much later as a psychologist. There's still a lot of stigma out there around mental health. So mostly people are coming to you first. And that's even true before they go to the school a lot of the time. Now, schools often will come to parents first and say, hey, you need to figure out what's going on here. But you're really the first person that they're going to come ask these questions to. So you're in a really strong position to influence how these outcomes show up for kids. Okay, so I'm aware of the time. I've been talking a lot, and I know that we typically save questions for the end. So I'm going to pause here to answer any questions, if there are any, for a little bit. And then if anyone has a case presentation that they'd like to talk through, or if you'd like me to present one, we can take time for that in just a second. So I know I've been throwing a lot of information at you. What questions do you have?
Feel free to unmute yourself if you'd like to go ahead and to present a case. We do have one from Dr. Marin that is in the chat, Dr. Kushanas.
Great.
I don't know, Dr. Marin, if you want to unmute yourself and share this. If so, feel free. I'll give you just a minute to do that. If that doesn't work for you, I will read it off to Dr. Kushanas. I'm not sure if you can read it or not.
Yep.
I
Hello?
can.
Yes, I'm here. It's Dr. Marin. My question is really about more chronic stress. I see a lot of kids with trauma that have been, devastating, but also they re-experience because it's unstable environments, like they don't live with their parents, they're in foster care, or they live with a grandparent, or parents come and go, or it's a lot of economic stress, or just like really unstable circumstances. Any thoughts on that, how we can deal with that? Because they do come in for other things, and it's just hard sometimes to go back and say, oh, this is trauma or something else.
Yeah, absolutely. I think that really kind of circles us back to this contextual ecological kind of system is really helping to identify areas that are going well and helping maximize those. So if they're doing a good job at school, get them more involved in school stuff. If they have a family friend that babysits them that they really like, get them more connected with that person. Ask if they can spend more time with them or other role models. That's one way to think about it. The other thing is making sure that you're getting your other systems of care involved. So I know this can be the hardest part because it does take so much time to collaborate care with other providers. But if you know that they see specialists, if you know that you have access to a social worker, I know that you have access to CPAN and T-Chat services. So make sure you're leaning on these resources. And what I always recommend is schedule follow-ups a little more frequently with these patients. So if you're worried about them, I know that there's a factor that comes in here with access to care, and being able to get back into the doctor can be really cost prohibitive for a lot of families. But if you have the option for virtual check-ins or phone check-ins, MyChart messaging, whatever you can do to get connected with these patients, follow them a little more closely, put some reminders on your schedule to do that, or make sure that your teams of care are really helping stay connected with them. Sometimes patients and caregivers are a lot more capable than they think that they are of kind of following through on our recommendations. So you don't have to be the one doing it for them all the time, but it can be helpful for you to be reminding them like, hey, remember we've got, you know, the social worker who wants to help you get connected to transportation to make sure you can get to school on time, or to your medical visits, or to your trauma follow-ups. And it's going to be really important to do physical therapy. So those kinds of things that we know we can help facilitate. It can be really helpful to just maintain more frequent communication, even if you're not the one providing that care. Does that help, Dr. Marin?
Yes, thank you.
Yeah.
Any other questions from attendees?
Dr. Gushana, thank you. Great presentation so far. Dr. Lazy here from Tyler. One of your slides, one of the risk factors, you talked about neurodiverse risk factor. I was wondering what do you can you elaborate on what you mean by neurodiverse?
Yeah, neurodiversity is, I guess, probably a more recent term in the past 5 years of literature. And it really describes, it's actually a patient, a self-label. I think that a lot of patients give themselves, but it really encompasses neurological and neurobehavioral disorders, or diagnoses that are high frequency that impact patients in the sense of their functioning is different than what we socially expect as normal. So this typically includes things like autism spectrum disorder, or the old school Asperger's syndrome, which is now under that umbrella of autism. It includes things like ADHD, dyslexia. Sometimes it can include neurological deficits that are acquired from injury, TBI. So anything where the patient might function differently because of their neurological makeup, whether that's acquired or something that is more organic. They kind of fall under this category, and it's basically a way to destigmatize and not place blame on the patient because they can't do something or they can't perform or they're not functioning normally, and really kind of contextualize it back to what's happened to them. So whether it's this diagnosis or this event that changed their functioning in some way. There's probably some people here that have a lot more experience with that term that could do a better job, but that pretty much sums it up. Does that answer your question?
Good job. Yeah, it does.
Okay. I also can recommend, if you're not familiar with the Child Mind Institute, they're out of California. They publish some really excellent articles, and they have a really good one that's basically what is neurodiversity. So you can Google that, what is neurodiversity, Child Mind Institute, and it's got a really great article on it.
Thank you.
Thank you, Dr. Eloise. Anybody else have questions today? Okay, Dr. Gushanas, I'll let you continue on.
Sure. Well, I do have several case examples. I've been doing this work for several years now. One of them that came to mind that I thought might be interesting for you all was a child who experienced a very unique motor vehicle collision. He actually was in his house playing video games. He's an 11-year-old boy, and a car ran a stop sign in their neighborhood and into his home and into the room and on top of the bed where he was sitting playing his video games. And he was admitted inpatient at Texas Children's Hospital in Houston and was treated for TBI. Part of the wall when the car impacted the house hit him pretty hard on the back of the head, and the mattress somehow flipped over on top of him, and so he was kind of squished, not to a very extensive extent. He was still able to breathe and get help and things like that. But his parents had been at the grocery store at the time, so he was getting like the rare time at home alone to play some video games without them disturbing him. It was a very big deal for the family to leave him at home at 11. Gone for 10 or 15 minutes, just running to the store, and then they were coming right back. So of course this happens when they decide to do that. And the child goes in for inpatient. He's treated for about a week, stabilized. He was on low stim precautions, just taken well care of in the inpatient post-trauma unit, and then discharged, and his pediatrician followed him and started noticing several of these symptoms, like all of a sudden having what teachers are saying ADHD. He can't focus in class, which you probably know is a pretty common neurological complaint after a TBI. But they found this was persisting a little longer than they expected after all of the other symptoms had resolved. So we had a primary care provider who had been getting lots of complaints from parents in the school about, you need to evaluate him for ADHD, he needs to be medicated. And then we also were starting to have some sleep disturbances once she looked into it a little bit more. So she was noticing that they were complaining he wasn't getting very good sleep. Maybe that's what was causing his concentration problems at school. He was also a little bit irritable, a little testy with parents, and developed a really intense separation anxiety, which was not like him before. He was actually asking to be more independent, have more time at home. But now it was anytime he was going to be separated from parents, he would become very anxious. So he'd have lots of questions. Where are you going? When are you going to be back? What are y'all doing? Who's going to be here with me? Where am I going to be while you're gone? And even going to school became really hard for him, just separating from his parents at drop off. And he was not able to ride the bus anymore. It was too scary for him to get on the bus without parents being there to kind of facilitate the transition into school. He also started developing heart palpitations and feeling like he was having difficulty breathing, which his family and him thought maybe was a secondary trauma or a secondary physical trauma from the accident. So they were doing lots of follow-up visits with providers saying, this new symptom popped up, like, we don't know if it's related, can you check on it, can we do some testing, that kind of thing. So pretty much across the board, he was experiencing symptoms in every category of post-traumatic stress. And our provider, thankfully, I had worked with her before, and she was tracking these symptoms, and over time realizing, okay, these are starting to all happen, not with more frequency, but together as a symptom cluster that looked like post-traumatic stress. And so once it got to that point where she started saying, you know, I think that this might be a stress reaction to what's gone on, she started providing some education to him. And as the time went on, symptoms did not improve. She screened him for PTS, and as he started kind of showing an increase, she referred him to our outpatient clinic. So we did have an outpatient clinic that providers could refer to directly from the inpatient and outpatient follow-ups for pediatrics. And so he was able to get connected to our clinic and come in for post-traumatic stress therapy, which in kids is called trauma-focused CBT or TFCBT. And we were able to resolve a lot of these factors, including a lot of those medical symptoms or physical symptoms that he was complaining about. And I would say probably about 12 weeks. So he did really great. He was very successful. He was able to start playing video games, and parents were able to let him be home alone again. By the time we finished treatment, his heart palpitations, his ADHD, all resolved with some work on him learning to manage that stress response system when it came up, using things like diaphragmatic breathing, but also a lot of education about how this is normal. After you experience something really scary like that, your brain's going to be doing a lot of work trying to figure out what the heck happened. And so let's not Let's not take these things out of context as individual experiences or symptoms. Let's think about it as the whole of, this is what happened to you not that long ago. How can we help support you, and making sure that we're taking care of some of these symptoms from that perspective. And it ended up working out really well for this kid. I also had his nurses and his PCP doing a lot of education, a lot of checking in, asking him to talk about how he was thinking and feeling about what happened, because a lot of times those things are avoided. A lot of people don't want to ask questions, and there is some research up front that says right after a trauma has happened is actually not the time to press for details, so that can actually solidify the traumatic reactions. So like within minutes or days of something traumatic happening, we don't want to ask them to repeat the story or tell the story again and again. That's why sometimes when there's legal involvement, it can be really difficult for patients because they're having to repeat their stories over and over again. But we know that after time, it's actually beneficial. It helps decrease that hypervigilance, and it decreases that stress response system because their system is no longer detecting a threat when they get used to telling that story over and over again. Very similar to any kind of exposure therapy that you might do with your patients around taking shots or swallowing pills, things that are scary for them, but as they practice, they get more mastery and competency and feel more confident that they can handle it. Same thing with trauma stories. So I had the nurses ask him every time he came in, hey, how are you doing? Have you been playing video games? Have you been thinking about it? Tell me about your nightmares. And just getting him to talk about what was in his head. It gave him a little more control over those memories and over those re-experiencing events. And over time, it became easier and easier for him to not respond really with a high stress response reaction to those things when they popped up, because he was used to thinking about them. He was used to talking about them. Okay. I think I left us a few more minutes for questions. If anybody has any about that case or any others.
Thank you very much, Dr. Gashanas. So I am opening this back up again for questions. If you would like to unmute yourself and ask anything about trauma assessment and diagnosis and pediatric primary care, please feel free to do so. If you are not able to open up your mic and would like to put your question in the chat, that's fine too. So anybody have questions?
So if you thought that they had like, if you thought that they had a traumatic experience, but like they're a new patient, they've just established care and their symptoms match a traumatic response, but you don't have that in their history, how would you screen that?
It's a great question. The simplest answer is ask them, have they ever experienced anything life-threatening or very scary, like a bad accident or being robbed or a child being abused, being hurt by someone, being touched inappropriately? So you can ask them those questions directly, yes or no. That's the easiest way. But there also are several standardized assessments you can incorporate into your screening tools. You can have your nurses or residents do this in the HEADS assessments for standard well-child visits. Just work these questions in naturally to the evaluations you're already doing. If you or your clinic is open to it, I highly recommend a screening tool to just put in for any new patient. Although the caveat is, of course, feeling like you have the appropriate resources to refer them to if they screen or say yes. And so, or if they say yes and they're experiencing symptoms of stress. So you can see here, healthcare toolbox is listed here, as well as the pediatric traumatic stress toolkit. The care process model is a very well-developed model. They have some good screening tools. And then, of course, these screeners that I've suggested here, the CATS and the CPSS-5, these middle two, they both have checklist screeners where it's like 10 questions, 10 to 15 questions, yes or no, has this ever happened to you? And you can actually have patients fill that out. If you're at UTMB, by the way, we already have this in our EPIC system. So it's already under screening for any patient. You can go and click trauma screener and click through these yes or no questions.
Okay, thank you.
Mm-hmm.
I did want to mention for the providers in Tyler, the CPSS is available, and that is included in the toolbox of screening tools we provide when you're registered for our services.
Nice.
There's another great question here from Felicia Abram, and if it's Dr. Abram, my apologies. What is your recommendation for a young adult who experienced a traumatic event or experienced a traumatic experience as a child, but is now in early adulthood, such as college? And again, that would fit within our CPAN age range as well.
Yeah, absolutely. The recommendations honestly don't change. So I would suggest looking at the healthcare toolbox resource I've suggested and this kind of section of treating PTSD if you know that they're experiencing symptoms. The CPSS-5 is actually intended for adolescents, I believe, up to like 21, 22. But to be very honest with you, the symptoms for PTSD do not change much from child to adulthood. They might present differently, but these screening tools can be helpful across the board. And then I included the PCL, which is a very short screener that's appropriate for older teens and adults. So you can always use symptom screening to check on this patient. And then those resources that I provided at the very end, they will have suggestions for how to respond in terms of referral to care. But any trauma-informed mental health provider, contact CPAN, ask them for resources, is a good way to approach it. Or recommend, a lot of colleges have free counseling access, so recommend they go to their student counseling services and get screened for trauma.
I'm going to share the QR code again, and that is earlier in the chat, but here's the QR code. Dr. Kashanas, feel free to continue. There are a couple more questions in the chat. Are you able to see those?
Yes, I got them. From this Dr. Villa.
Yes.
Okay, so some of the potential long-term effects of traumatic stress. Yeah, unfortunately, that's beyond the scope of this presentation. I could talk to you about this, though, for sure. And we do have another presentation that goes into this. I'm happy to send you a little bit more information, Dr. Villa, but the most common long-term effects that we see besides specific disease risk is just difficulty functioning for the symptoms that we discussed earlier. So really interfering with functioning, like going to work on time, maintaining adequate relationships, functioning in the sense of like driving if you had a bad car accident, or communicating if you've been a victim of domestic violence or assault. It's really about interference with functioning when it comes to trauma. We do know that a lot of people who experience traumatic exposure in childhood do have higher rates of other mental health concerns, as well as higher rates of incarceration and financial difficulties in adulthood. So those relationships aren't always well defined in the literature. But there are definitely a lot of adult outcomes that we see in these kids, which is why we're trying so hard to promote early identification and intervention. And providing balance with screening and minimizing the risk for re-traumatization is super important. My best recommendation there is to let them know that this is standard, and these are questions we're going to be asking Most screening tools say at the beginning, this questionnaire asks questions about difficult things that some people have experienced. So making sure you're communicating and really preparing patients to know. We might ask some questions that are really uncomfortable, but most people find that the screening process is not as re-traumatizing as the lack of attention. So actually asking about trauma, this applies for things like suicide risk as well. Most patients provide it more or say that it's more comforting to be asked, even if they don't want to disclose, than it is to not be asked. So it's a risk that we say is worth the wait.
Thank you, Dr. Gashanis. So we are at the top of the hour, and I am going to stop sharing. Hopefully. There we go. And I want to thank Dr. Gashanis for her time today and her expertise. I believe we had up to upwards of 53 individuals on this session today, so very excited. It's a topic that is so important, and I suspect it's an issue and problem across the state of Texas. Trauma is definitely a huge issue that we deal with here in Northeast Texas in our rural communities. And we thank you for your expertise today. Thank you all for joining us. We will be having another session. Our next one, I'm checking my calendar here, will be on the 13th of November. Our own Dr. Taya Johnson will be presenting the molehill that became a mountain, addressing child and adolescent mental health early. So it's definitely not a watch and wait kind of situation when we're dealing with child and adolescent mental health. It's let's deal with it while it's still a smaller issue. So thank you again today, Dr. Gashanis. We really appreciate your time. Will you be sharing your slides with us?
Yeah, absolutely. I'm happy to do that. And I'm happy to be available for if you have questions or other resource requests.
Okay, I will put the CPAN, the Tyler CPAN email address in the chat, and if someone's interested in those slides, they can certainly reach out to me. Dr. Gashanis, have a fantastic day. Thanks again for helping us out, and we thank you all for being here. Have a great day.